Are we streaming? Good. Okay, welcome all back to this afternoon session. It's the first poster session of this conference. The way that it's going to work is that we are going to have 8 poster presentations, actually 7, and they are going to be 3 minutes maximum each, and there will be no question for this time because time doesn't allow it. So if you have any question, you can ask it directly to the author, just by reaching them at their email address, which should be found in the conference booklet. So now I give the word to the first poster presentation.
May I start?
Yes.
Hello, good afternoon to all. I am Dr. Pejkova from University Clinic for Plastic and Reconstructive Surgery, Skopje, North Macedonia. Today I will speak about correlation between neuromas and phantom limb pain after traumatic hand amputation. Hand injuries in our country are quite common, and especially in people coming from the rural parts of our country where they work, they are agricultural workers, they use different types of machines without appropriate protective equipment. That is the main reason for mutilating hand injuries, where the option is unfortunately limb amputation. Shortly after amputation, patients report presence of phantom pain, and many researchers have noticed that phantom limb pain and painful sensation at the stump are correlated with symptomatic neuronoma formation. Following that direction, we evaluated 6 patients admitted at our clinic. We analyzed patient demographics, level of amputation, and the use of prosthesis. Furthermore, we analyzed phantom phenomena and stump pain related with symptomatic neuronoma detected with ultrasonography. The average age was 45 years and the youngest patient was 18. All of the patients experienced phantom sensation. 3 patients complained of phantom limb pain and stump pain. 2 of the patients were using painkillers or pain relief. Only 2 patients are using non-functional rigid prosthesis for less than 8 hours per day. Ultrasonography detected painful neuromas of the median and ulnar nerve correspondent with the positive T.A.L.A sign on the clinical examination. Phantom phenomena after amputation are limiting everyday activities. Description of the pain and sensation differs between patients and usually is dependable on the age, social background, profession. Presence of painful neuromas limits the use of prosthetic devices. The results of our study indicated that even in the emergency surgery procedure for traumatic amputations, primary treatment of the nerve should be taken in consideration. At transradial level, a nerve should be located away from the stump and surface and buried in the nearby muscles to prevent neuronoma formation. 4 of our examined patients from the study are already scheduled for the revision surgery for persisting painful neuronoma. Our goal is to eliminate the pain and to provide them a functional prosthesis. Hopefully, we won't anymore see sad faces like that and give them a chance for more fully painful life. Thank you.
Thank you. So the next poster presentation.
Fantastic. Hope you can all see that. Thank you very much to the conference organisers for asking us to present our data today. My name is Dr. William Goodison, Registrar in Rehabilitation Medicine, working at the Royal National Orthopaedic Hospital. So I'm presenting today on our study of a retrospective review of phantom limb pain in patients undergoing lower limb amputation as a result of diabetes. So late complications from diabetes resulting in lower limb amputation make up a large proportion of new primary referrals to amputee rehabilitation centres in the UK. There are around 1,500 major lower limb amputations attributed to the disease in the UK each year. So understanding how this cohort progresses after amputation is of vital importance in their rehabilitation. From our clinical practice, we've often found that this group of patients appears to report phantom limb pain less regularly than other patients. However, the only work that we think to look at this previously was published in 2013 and demonstrated no difference in phantom limb pain prevalence between diabetic and non-diabetic patients. We therefore retrospectively reviewed all new lower limb referrals to our prosthetic rehabilitation unit over a 1-year period, looking at adult referrals only. We collected data on the cause of amputation, presence of phantom limb pain, phantom limb sensations, and residual limb pain, as well as the number and type of analgesics and the presence of premorbid neuropathy in the diabetic patients. In total, we reviewed 51 cases, 23 in the diabetic amputation group and 28 in our control group. The demographics presented here were largely equal between both groups. When we reviewed the data, we found there was a significant difference between the incidence of phantom limb pain in both groups. 39% of patients in the diabetic amputation group reported phantom limb pain post-amputation compared to 75% in our control group. There are no significant differences between the incidence of phantom limb sensations or residual limb pain. However, the reported incidence was lower in the diabetic group for both phantom limb sensations and residual limb pain. Patients with amputation secondary to diabetic complications were also on fewer analgesics at presentation compared to the control group, with fewer opioids prescribed as well. Of the diabetic group, 60% had a premorbid lower limb neuropathy. However, there was no significant difference in the incidence of phantom limb pain between patients with neuropathy and those without. Whilst we appreciate this is only a very small retrospective study, we can potentially hypothesize that diabetes may have an impact on the experience of phantom limb pain post-amputation. It's known that patients with advanced diabetes are likely to have changes in both the central and peripheral nervous system caused by the disease. In our cohort, though, the presence of a sensory neuropathy before the amputation was not associated with lower levels of phantom limb pain. However, we do caveat that with the very small numbers included. This may suggest the effects of diabetes on phantom limb pain are not entirely mediated by its effects on the peripheral nervous system. For example, diabetes is known to impair cortical plasticity and functional recovery following ischemic stroke, for example, and thus could impact on the reorganization of the somatosensory map following amputation, thus impacting on the patient's experience of phantom limb pain. This work presented today has many limitations, and it's only scratching at the surface of how diabetes and phantom limb pain could interact. Ultimately, further work is required to look specifically at the central and peripheral effects of diabetes and how this affects the proposed pathways of phantom limb pain, potentially providing another piece of the puzzle. Thank you very much.
Thank you. We can move on to the next. We cannot hear you.
Rehabilitation of the Residual Orthopedic Institute of Bologna. And today I present to you my study entitled Chronic Pain in Lower Limb Amputees and Correlation with the Use of Perioperative Epidural or Perineural Analgesia. Chronic postoperative pain is a common complication in patients who undergo amputation surgery and has been distinguished in 3 main conditions: phantom limb sensation, phantom limb pain, and standard residual limb pain. The aim of the study was to evaluate the long-term prevalence of ICPLP and RLP in patients with a lower limb amputation and their correlation with the perioperative analgesic treatment with epidural or peripheral nerve block. The study lasted for a total of about 20 months. Patients operated on above knee, below knee, and hemipelvic amputation of any etiology at the Residual Orthopedic Institute between 2008 and 2018 were enrolled to the Institute Data Processing Center. Suitable patients were asked to fill out questionnaire including anthropometric data, the current use of drugs for the management of pain, any physiotherapy after amputation, the Newton scale for prosthetic use, and the prosthetic evaluation questionnaire to evaluate the presence of chronic post-surgical pain. Out of 207 eligible patients, we obtained complete questionnaire data from 79 amputees. Follow-up time for amputation was 5.1 years. The most frequent cause of amputation was cancer or infection. PLS was reported by 68.5% of amputees, PLP by 65.9%, and RRP by 53.3%. No correlation was found between the use of individual epidural or perineural catheters with the presence of chronic post-amputation syndromes at a mean follow-up of 4.4 years. However, patients that were due to catheters, sciatic femoral or peridural femoral, had 6 times the likelihood of not having PLP with respect to patients with don't have catheters or had only one. In conclusion, the use of a combination of 2 catheters results in the possibility to have less incidence of phantom limb pain in long-term follow-up. Thanks all.
Thank you. We can move to the next.
Good morning. This is Clay Smither. 1 year ago, I completed a amputee rehab fellowship at the VA in Central Virginia. And during that year, we certainly treated a lot of amputees who had phantom limb pain. So today I'm presenting a case series on novel treatment for phantom limb pain. Case number 1, we had a 78-year-old male with type 2 diabetes mellitus and peripheral vascular disease. And he required a left transfemoral amputation due to foot gangrene. Now, it was actually 3 years after surgery that he presented to us with really severe residual limb pain and phantom limb pain, very severe, worse at night. He had trialed extensive treatments, including a TENS unit, multiple oral analgesics. His pain was not well controlled. So we treated him with an ultrasound-guided left lateral femoral cutaneous nerve block. The first was with lidocaine and depomedrol. He had some improvement in pain, but several months later, this pain did return and was again 10 out of 10. The second time we treated him was again the left lateral femoral cutaneous nerve block, but this time with 50 units of Botulinum Toxin A. So it's a version of Botox, and 1% lidocaine. This time his pain was decreased to 4 out of 10 immediately after, only lasted a short time, 1 week, and he actually went on to peripheral nerve stimulator placement and did have improved pain relief after that. And then our second case was case number 2 is a 69-year-old male. He also had past medical history of diabetes and peripheral vascular disease, end-stage renal disease. He also required a right transfemoral amputation due to an infected foot wound. Now, 1 month after surgery, he was having really significant phantom limb pain, and it limited his progress with therapy. He rated this pain as quite severe, 8 out of 10. Multiple medication trials did not help his pain, and so we did treat him with an ultrasound-guided right lateral femoral cutaneous nerve block with 1% lidocaine and 50 units of Botulinum Toxin A. Immediately after, his pain went down to 2 out of 10, and in later weeks, his lowest pain went to 0 out of 10. It did average 5 out of 10, so overall some improvement, but not complete resolution. So just with this case series, there is good support for role of nerve blocks to reduce phantom limb pain. It is temporary in nature, but can also help obtain goals for possible peripheral nerve stimulation. So this will be kind of a good introduction. Dr. Murphy and his team are presenting a workshop tomorrow morning on peripheral nerve stimulation. Thank you very much.
Thank you. So we can move on to the next presentation.
Oh, sorry. Thank you to the conference organisers for inviting us to speak and share our experience. We're presenting on our early experience of targeted muscle reinnervation for phantom limb pain in lower limb amputations. So targeted muscle reinnervation for the management of lower limb phantom limb pain and neuroma pain is a new application of an existing technique. TMR was initially developed in the upper limb for myoelectric prosthesis control, and incidentally found to improve pain outcomes. A randomized controlled trial published by Domanian et al. Back in 2019 showed improved phantom limb pain in major limb amputees at 1 year. And our work further shows that the technique of TMR can be translated into the amputated lower limb, where the primary issue is pain. So the image here on the slide is to illustrate our posterior approach that we take, where sensory nerves are identified and divided, and then coapted onto newly divided motor nerves, which we identify with nerve stimulators. And the coaptation is performed using nylon microsutures and then standard wound closure. So in terms of our methods, we used prospective analysis to look at our cohort of adult patients only, and with operations performed by a single surgeon, Lieutenant Colonel Tanya Goodison, senior author. This was both primary and secondary TMR, and the indications were pain of all kinds, so neuroma, phantom limb pain, or chronic pain. The data that we collected, primary outcome data of pain scores, visual analog scores, and quality of life using the SF-36 questionnaire. We also established our own assessment tool of assessing total pain burden. This was used due to the limitations that we know with standard pain assessments. And we looked at sort of taking a global view of the patient's total pain burden and looking at a percentage change from pre to post-operative. We also noted the anesthesia type, general complications, and analgesic use. So in terms of our results, we've had 33 consecutive patients. There's in fact more since time of writing, 21 male and 12 female, of which a variety of both military, veteran and civilian patients. Our average age of 49. And one of our cases we performed under local anaesthetic. Obviously the majority have been performed under general or spinal, but it is interesting that this can be performed under local anaesthetic, we felt. Of our patients, the majority were transtibial lower limb amputees, and 6 of our patients were primary amputations. Something which we thought worth noting was 100% of our patients were pleased that they had had their surgery and felt that their total pain burden was reduced post-operatively. So in conclusion, we feel that targeted muscle reinnervation does have the potential to improve pain management in our lower limb amputee patient cohort. We found in terms of our early experience that there is potential pain fluctuations in the early post-operative period, particularly sort of months 3 to 6, and we have further outcome data awaited. Also of interesting to note that the procedure may be performed under local anaesthetic in select cases. Thank you very much.
Thank you. We can move on to the next presentation. You may start to talk your presentation. You have to unmute yourself. On the left corner, lower left corner, you may find the button to unmute yourself. Lower.
Yeah.
Okay.
Can you hear me now?
Yes.
Okay. So thank you all for joining my presentation, my poster presentation. And I'm Dr. Jadidi from CNAP Group, Center of Neuroplasticity and Pain. And the title of my presentation is the effect of pulse with modulated sensory feedback on cortical excitability. And for the introduction, as we all know, conventional TENS intervention has been reported to be beneficial for chronic pain patients, including amputees with phantom limb pain. And depending on the TENS parameters, frequency, the pulse width, amplitude, and the pattern, they induce changes in the cortical activity of the sensory, somatosensory cortex and motor cortex, and the subsequent rehabilitative effect may differ. And in the recent past years, there has been a growing interest in investigative alternative pattern rather than the non-modulated and conventional pattern to improve the efficiency and efficacy of the rehabilitation. And the pulse-width modulated pattern is one of these interesting approaches, and it has been tested on chronic back patients. However, it remains unsolved that how this modulated tense pattern influences CS excitability and possible CS biomarkers for the pain alleviation. So in our project, we take a step back and try to evaluate and compare the responsiveness of the CS pathway following the application of different TENS intervention. This work is a small part of the bigger work of my PhD, and we have tried different TENS patterns and also different evaluation types. But for now, as you can see here, for the method, we have applied two different TENS interventions, the non-modulated high frequency and the pulse-width modulated with the same frequency and different pulses. And we recorded the motor work potential, which was induced by the TMS pulses, before the intervention, immediately after, and 30 minutes after the intervention phase. And we have applied the electrical stimulation on median nerve, and we recorded the MAP from two muscles, right ABP as a target muscle, right FDI as a non-target muscles, and left ABP as a contour muscle. And for the results, as we have expected, similar to the previous report, the results from the conventional TENS pattern with the 100 frequency increased the induced changes and with the facilitation trend. And but it wasn't significantly different in our project. But the novel finding was that the pulse-width modulated intervention induced changes and increased and enhanced the corticospinal excitability immediately after the intervention. And also the other finding was that while the ABP muscles, which was median nerve innervated muscles, has been experienced changes, but the two other muscles, the right FDI and the left ABP, remain unaffected. So as for the conclusion, the pulse-width modulated TENS pattern increased the excitability of the CS pathway significantly, while the conventional didn't. And our findings suggest a focal and specific rather than the global effect of the delivered TENS pattern on the stimulated nerve innervated muscles. And it supports the clinical studies covering intervention leading to facilitation, the CS activity, and PAP elevation, like the anodal PDCS and also the high frequency RTMS. And maybe this pulse-width modulated TENS pattern may be considered as a beneficial therapy for PLP elevation in the future, but for sure additional studies are needed to validate our results. And it's the second part of my project over my PhD, which is almost an ongoing state. And yes, we can compare the we can conduct the comparative analysis on healthy subject and amputees to find a possible CS marker for the pain alleviation. Thank you all, and thanks for listening. I put my email here, and you're still welcome to ask me a question later to discuss with more detail.
Thank you. And now we can move to the last poster presentation for today.
Good afternoon. My name is Michael Bressler. I'm working as a PhD student at the Eberhard Karls University and the Trauma Clinic in Tübingen, Germany. And I'm very glad for the opportunity to present to you today C.A.L.A, which stands for Computer Assisted Limb Assessment. The idea for this project originally comes from our need for a tool that is able to visualize and also document the phantom sensation of amputees. And since we could not find such a tool, we decided to develop it by ourselves. So we created a prototype based on the idea of having a 3D avatar that can be customized easily by moving around sliders, so no need for skills of modeling a 3D person. And this avatar has the following functionality. First, you can adjust the 3D avatar in terms of gender, age, and body shape. Also for the patient to create some identification. Then you can adjust the phantom limb in terms of its shape So for example, you can create effects like telescoping. Then you can adjust the phantom limb's position. And finally, you can draw in the intensity of pain and cramps. And finally, that's also one of the goals for this project, you can quantify the data entered to make it measurable and also to be able to monitor their changes over the course of therapy. We evaluated this prototype with 30 therapists, where we did a questionnaire, a system usability scale, to evaluate the acceptance and the usability of the software. And we did some questionnaires and semi-structured interviews to evaluate the functionality. And we also tried to model the phantom limb sensation of 20 real amputees to see if our functionality covers the whole range of what is required. So it turns out that the system was accepted to the high grade, 81% in the SUS, in the system usability scale. However, it turned out that we have to simplify the user workflow, especially since the time a therapist has to treat the patient is limited, and therefore this process of modeling the phantom should not consume too much time. And we also found out that it's actually, there is a huge range of phantom sensations, and we still have to implement some functionality to be able to cover this whole range, especially when it comes to modeling the sensation of fingers and the hand. But it's also, so turns out that pain is a huge topic for the patient. That was new for me since I'm a software engineer actually. So we plan to create a finer differentiation of pain in the final version. And we also want to document the residual limb pain, so we have to make a clearer differentiation between the phantom limb and the residual limb, which is not given in the prototype, where there is only one model where you can draw in. In conclusion, C.A.L.A prototype seems to provide a sufficient method for visualizing and documenting phantom limb sensation. And we want to create a final version based on the feedback we have collected over the last month. And this final version is then supposed to be used in a multi-center longitudinal study to document the whole patient collective. Thank you.